This is it's really a pleasure to be here tonight. It is a long way, but it's not so long compared to going to other places in the world. It's my 4th time in Israel, and I've been fortunate that every time I've been here, the weather has been fantastic, so thank you. Just a word before I begin. I'm going to be talking about the vaccine, Zostavax. Barbara, Dr. Jan gave a great introduction of why and what the benefit of this vaccine might be in terms of preventing significant morbidity amongst individuals, particularly older individuals. I should say that I personally have experience in my family, a couple of mothers-in-law who basically have died not of zoster, but died with zoster, and basically in a hospital setting. And I have been vaccinated. I certainly am old enough to be vaccinated. I think there are plenty of people in the audience who might also be eligible for the vaccine in Israel as well. So what is Zostavax? Some of you probably know about it already. You've spoken to some folks from MSD, or you've read about it in the journals. Here in Israel, it's a frozen vaccine. It's the only licensed vaccine in the world for the prevention of herpes zoster, and that's the indication here in Israel, the prevention of herpes zoster. It's a live, attenuated vaccine that is basically the same virus that is used in Varivax or the chickenpox vaccine. The only difference between the two is it's 14 times as potent as the chickenpox vaccine. People ask why that's the case. Well, the simple reason is adults don't respond as well to lower doses of the vaccine than the higher doses. And so this is the level of antigen that you need to have in the vaccine in order to get a good immunologic response that will lead to prevention of the disease. It's a lyophilized product, which means it's freeze-dried and has to be reconstituted before use. And its reconstitution can, once it's reconstituted, it has to be used within 30 minutes of actually reconstitution. And it's a single dose. Right now, there's no indication for a booster dose. Dr. Young actually talked on a couple of her slides about immunocompetent and immunocompromised patients. And I want to emphasize here that this vaccine is for use in immunocompetent patients, not in immunocompromised patients. Although immunocompromised patients tend to be actually at even higher risk for developing zoster, patients with, for example, HIV or leukemia or lymphoma, or people on chemotherapy. But as a live attenuated vaccine, it's not indicated in those populations. And so these are the kind of conditions that might be contraindications for the vaccines. But at the same time, individuals who have one of these conditions, also the vaccine can't be used. And what I actually wanted to say is these are individuals who excluded from the clinical trials that led to the licensing of the vaccine as well. Dr. Jan showed a very nice slide about how the virus basically lies dormant in the spinal cord and then for one reason or another reactivates, begins to grow again. We don't really know exactly what stimulates it, but we know that age and immunocompromised conditions will lead to that. And if you think about it, this is, as I say, a very nice schematic. Individuals get infected when they're children, generally speaking, for the most part. In fact, if you measure antibody levels in people over the age of 40 in most parts of the world, they all have indications that they've had chickenpox as a child. Essentially, they have stimulation of the immunologic system, particularly varicella zoster virus T cells. That's the major component of immunologic protection. As they go through life in countries where chickenpox vaccine is not used very much, they may get exposed to chickenpox through children, and they get a little bit of boost then. They may have a little bit of internal boost. The virus, although it's dormant in the dorsal root ganglia, may grow a little bit, that might boost immunity. But eventually, as they age, their T cell level may go down, their VZV specific T cell level, and they get into what we would consider the risk zone for herpes zoster. Now, not everybody is going to get it, but clearly, as Dr. Jan indicated, a fair number of people do. And if they get Zostavax, they can boost up their immunity and prevent falling into the risk zone. So what I'm going to talk about a few studies. The first two, the shingles prevention study and the Zostavax efficacy and safety trial, were really the pivotal trials to lead to licensure of the vaccine for those who are 50 and over. And then I'm going to just mention a couple of other studies where Zostavax was used concurrently with either influenza vaccine or pneumococcal 23 vaccine, pneumovax 23 specifically. I want to mention, I did say that immunocompromised patients aren't eligible, but over 90% of the people who were enrolled in the first 2 clinical trials had some sort of chronic condition, something like hypertension or diabetes or osteoarthrosis, and most of them were on at least one other medication. So we're talking about people who have other comorbidity, and with comorbidity, when they get shingles, clearly they have a more complicated course. So the first study, this is the build slide, this was published in the New England Journal of Medicine. This is the sort of clinical, this was basically a collaborative study between the VA, the National Institute of Health, and Merck. And it involved about 38,000, a little over 38,000 people total, half in the vaccine group and half in the placebo group. And the primary hypothesis was basically to look at whether the vaccine was efficacious in reducing the incidence of zoster, the severity of disease, and post-herpetic neuralgia. All these subjects were followed for safety throughout the course of the trial, but there was also a sub-study that looks more intensely at individuals with much more active reporting of potential side effects. There was also an immunologic sub-study that I'll mention in a moment. The more focused safety study had about 6,600 people, and the immunologic study had about 1,300 people in it. So these are the results of the major results from the shingles prevention study, or SPS is what we call it. And overall, in those who were 60 and over, because that was what the study was focused on, and the age ranged up to almost 90 in that study, the vaccine was efficacious in 51% of individuals for reducing the incidence of herpes zoster itself. But I should say that the vaccine efficacy varied by age, with a little better efficacy in the 60 to 69 population and a little bit lesser efficacy in the older population. And this slide here shows how it breaks down by age. Same study, but broken down by age, and you can see that in the 60 to 69 group, vaccine efficacy was 64% for preventing the incidence of zoster. In the 70 to 79 population, it was 41%. And in those who were over 80, it was 18%. Now, those over 80, you can see the confidence interval is quite wide. This study was not designed actually to test to see whether it reduced the incidence in the over 80 population. It actually was broken down into 2 groups, 60 to 69 and 70 and over, but in this slide we broke it down into 3 groups. If you look at what the vaccine efficacy for reducing the incidence of post-herpetic neuralgia, and post-herpetic neuralgia had a very specific definition in the study. Dr. Yan referred to it. It's anybody who had essentially pain of 3 or more on a scale from 0 to 10 for more than 90 days from the onset of their rash. So it's a very specific definition, and about 12% of the individuals in the shingles prevention study actually went on to have a post-herpetic neuralgia. And if you basically look at the individuals, you see that the overall efficacy for reducing post-herpetic neuralgia in the entire population was about 67%. And this was true if you looked at the 60 to 69 population or those who were over 70. Again, if you're analyzing all the people in the study. If you broke it down just on the individuals who had herpes zoster, the efficacy was not the same, it was a little bit less, but it was particularly sustained in the 70 to 79 population, so that in that population, even if they got zoster, there was an attenuation of their disease. In other words, the severity and duration of their pain was less, even though they had the disease compared to the placebo group. So whenever we talk about the benefits of the vaccine, we need to talk also about the adverse events of the vaccine as well. What I'm showing you on this slide is the sub-study that looked at safety in about 6,600 individuals. It's a little bit of a complicated slide, but I want you to focus on is over here. What do I mean by solicited? Soliciteds mean there was actually a report card, and on the report card were a list of symptoms and signs such as pain in the local area, swelling, warmth, etc. And then these were unsolicited symptoms where people volunteered what their symptoms or signs might be. And I think it's quite obvious that, in fact, what you mainly have here are local effects. In other words, the vaccine, compared to the placebo group, was more likely 2 to 3 times to cause local adverse events than the placebo. That's not so good. On the other hand, most of those local reactions were mild to moderate in nature and resolved within a few days with basically just regular local therapy, nothing very specific. If you looked at systemic, these are the unsolicited events, and you notice here on the right you have systemic event, adverse event of headache, which was the commonest systemic adverse event. And on the next slide, you see that, in fact, if you compare the placebo and the vaccine group, that the overall adverse events, systemic adverse events, were equal in the two groups. 1.4% in the Zostavax group and 0.9% in the placebo group. So in terms of systemic events, which mostly, in many cases, was just headache, they were equivalent and non-statistically significant in the two groups. If you just focused on serious adverse experiences or events, in the overall study, where you compared 19,250 patients in each group, the serious adverse events were the same in both groups. Now, if you just focused in on the subgroup that had more intense follow-up for adverse events, what you had was the Zostavax group had 1.9% as opposed to 1.3% in the placebo group of serious adverse experiences. And that actually was statistically significant in the subgroup. But when you looked at it by organ system, even though it appeared to be slightly higher having cardiovascular events, these were not statistically significant. There was no specific event that actually stood out. Again, in the overall population, there was no significant difference in serious adverse events between the placebo group and the Zostavax group. And finally, if you look at immunogenicity sub-study, and I'm only going to show you the antibody level here. I'm not going to show you data on the cell-mediated immunity or the T-cell immunity, which actually is probably a little bit more important in immunologic protection. What you can see here overall is that the Zostavax, the vaccine, essentially had a much better immunologic response compared to the placebo. What you have here is actually a comparison to what the placebo response was before and after vaccination. And essentially there was no response to placebo, yet those who were vaccinated with Zostavax had almost a 2 times, 1.7 specifically, increase in the VZV antibody level. And if you looked at the cell-mediated immunity, you basically had a doubling in the geometric mean fold rise of the T cells, VZV-specific T cells. So together, both antibody and T cell response was significantly higher in the Zostavax group compared to placebo. So that's the shingles prevention study, 16 over. That led to the initial licensure of the vaccine in the United States and in many parts of the world. And actually, in many parts of the world, it was licensed for 15 over based on this basically data, because there was some other smaller studies that looked at 50 to 59-year-old individuals and basically saw a similar type of immunologic response. And so most countries said, well, that's good enough for us. We're going to license it for 50 and over. That wasn't the case in the United States. In the United States, the regulatory agency, the Food and Drug Administration, says, no, you have to do a study in the 50 to 59-year-old population and show that it works in that population, even though we know that there's probably a good immunologic response that's similar in the 60 and over population. So we did the Zostavax efficacy safety trial, which was focused on 50 to 59-year-old individuals. The shingles prevention study was only done in the United States. This particular trial was done in 5 countries, 105 sites around the world. 22,500 individuals, so not as large as the shingles prevention study. They were balanced at the beginning of the study on age, sex, race, ethnicity, and comorbid conditions. And the primary endpoint in the study was just to see whether it reduced the incidence of shingles itself. We didn't really study post-herpetic neuralgia groups in this group for a variety of reasons, but one of them is the incidence of post-herpetic neuralgia in this group is much lower than an older population. And the study probably would have to have over 100,000 individuals to actually detect a benefit on post-herpetic neuralgia. So what were the results? Well, it's summarized on this slide, but where to focus on this slide is this over here, which is the number for vaccine efficacy, which is almost 70%. So what that says is in the 50 to 59 population, the Zostavax reduced the risk of shingles by about 70%. So remember, 70% in this population of 50 to 59, it was 64% in the 60 to 69, it was 41% in the 70 to 79, and it was 18% in the 80 and over. So what does that say? It says that the immunologic response as a person ages is not as good as when an individual is younger. Now this is true not just for Zostavax, this is true for other vaccines as well. But I think this is a good demonstration of that. There was also immunologic study done, and I'm not going to show you the results, but essentially, as I mentioned earlier, the immunologic response to the antibody level was approximately 2.3 compared to the placebo group. This was done in a 10% sample of the population that were studied. So this is a summary slide for the various types of efficacy. You have on your left, overall vaccine efficacy 70%. For the 60 and over population, it's 51%. And when you're looking just at postherpetic neuralgia in the 60 and over population, it's 67% overall when you're comparing both the vaccine and the placebo groups. Two other studies that I think are important. There are many studies that are done around Zostavax. I'm only highlighting two of them, and there's going to be only one slide on each of these studies. One was the use of the vaccine concurrently with influenza vaccine given in separate arms. About 375 individuals, double-blind controlled, just an immunogenicity and safety study. It was not an efficacy study. And the bottom line for this is that giving the vaccine either 4 weeks apart or on the same day, individuals had the same immunologic response as measured by varicella virus specific antibody levels, and they had basically no difference in adverse events in the two groups. And the label basically reflects the fact that you can give the vaccine concurrently when the patient is seen in the office, thereby potentially avoiding a visit to the doctor's office. The other study that was done was using Zostavax concurrently with Pneumovax 23. This was done in a population of 60 and over in the US. Again, 4 weeks apart, and this was a little bit different. The safety was not an issue, same in both, local reactions mostly. But what's different is, and the response to the 4 serotypes of the pneumococcal vaccine that were measured were the same whether the vaccines were given concurrently or separately by 4 weeks. But the antibody level in the group that got the vaccines concurrently, the Zostavax, the zoster antibody levels, were actually lower than was expected. And so the label, although it was still a clinically significant right, it was statistically significantly different than the group that got it separated 4 weeks apart. So the label basically says in the US and here in Israel is that you need to consider giving these vaccines 4 weeks apart as opposed to concurrently. We get asked a lot about transmission. That's because it's a live attenuated virus, and so people are concerned, well, if I give the vaccine to people, do they have to be separated from individuals? Can they transmit it to someone at home? Well, theoretically, certainly, since it's a live attenuated vaccine, if you have someone at home who's never had chickenpox, it's conceivable that the person who was vaccinated could potentially transmit the virus to the individual if they've never had chickenpox before. If they've had chickenpox, they're likely to be protected. In fact, it might even boost their protection. Post-marketing reports have revealed that there may occasionally be, certainly with Varavax, with the chickenpox vaccine, there has been occasional transmission to individuals in the home, for example, who may have been unvaccinated or with chickenpox vaccine or never had chickenpox. In the clinical trials that I mentioned, the shingles prevention study and the ZEST study, there was no indication that those who were vaccinated with Zostavax transmitted the virus to anybody in the household. And I can say that currently there have been about 15 million doses of Zostavax that have been given to people around the world, mostly in Canada and the US up to this point. And there's been no incidents of documented incidents of the virus being transmitted from those who got the vaccine to individuals in the home. So clearly, for the most part, it's a theoretical risk. Potentially, it can occur. The vaccine is recommended throughout the world in a number of different countries. Each country has a different recommendations. As I said, in most countries in the world, it's licensed for 50 and over, but not every country necessarily recommends it for 50 and over. In the US, and there's some errors on this slide, unfortunately, that I can see, but the Advisory Committee on Immunization Practices, it's over the age of 60. The number 1 at the end actually should have been a superscript with some references on the bottom. In Canada, it's over 60, but it could be used in an over 50 population, and so on. In Israel, it's recommended for 60 and over by the Ministry of Health. So just some ACIP in the US, and I understand you follow those recommendations here in Israel. They do have a number of selected recommendations to try to aid the practitioner in basically utilizing the vaccine. They give some guidance on those who are not yet immunocompromised but might be anticipating immunosuppression. There's some recommendations on whether a person's getting antiviral medication. It needs to be stopped because antiviral medications will interfere with replication. Of course, antiviral medications, like acyclovir, usually has a short half-life, and so on. And I think I don't want to belabor this, but this is actually in the ACIP recommendations. So in conclusion, Dr. Jan summarized the sort of the burden of disease in the population, and clearly it's a disease of aging. It's also a disease of immunocompromise to some extent, or reducing or falling immune system, or what we call immunosenescence. Zostavax has been proven to be immunogenic, efficacious, and has a good safety profile in the targeted population. It's recommended in Israel for 60 and over, and actually it's 15 million doses have been distributed worldwide to date. And with that, I'm going to thank you for your time, and I'm here to answer questions if needed.